We're going to get started in a few minutes. We're just letting a few more people get in. So Carrie, I think we can go ahead and start.
Sounds good. Good afternoon, everyone, and welcome. My name is Carrie Shannard-Kunders. I am the Executive Director of the South Dakota Board of Pharmacy, and I chair the NASCSA Education Committee. I'll be hosting this afternoon's webinar along with NASCSA's Kathy Keogh. Hopefully you read the scrolling information while waiting for the webinar to begin. With the information regarding our sponsors, a NASCSA disclaimer, housekeeping items, and announcements. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. So thank you, sponsors, and thank you for taking time out of your, if you're like me, extremely busy schedule to join us for today's webinar, a joint approach to preventing drug diversion in healthcare. A webinar for state authorities. The boards of pharmacy have special interest in this topic as this seems to be occurring every day in healthcare, but detection often eludes us. I am very pleased to introduce our speaker, Tom Knight. He is a very knowledgeable presenter and has presented before for NASCSA, and he can shed some light on this issue. Tom is the founder and chairman of healthcarediversion.org, a 501c3 not-for-profit organization whose mission is to reduce drug diversion in healthcare facilities across the country. Tom is also founder and CEO of Invistix, a provider of software to detect drug diversion and improve controlled substance compliance. Tom served as the principal investigator in a national study funded by the NIH, National Institutes of Health, to improve drug diversion detection in hospitals. Prior to founding these organizations, Tom spent 10 years improving inventory management at Alcoa and Siemens. Tom is super smart. He holds 3 degrees from Massachusetts Institute of Technology. We are extremely happy to have Tom with us today. This should be extremely interesting as well. Hope you're looking forward to this webinar as much as I am. Tom, please enlighten us.
Well, thanks, Carrie, and thanks everybody for attending our webinar today. Really appreciate a chance to talk to you about our nonprofit. Some of you might be familiar with us. Others, this might be new information. I'll begin with our mission and goals and who's involved. I'll give you an overview of our approach and a quick demo of our website. But the real main question that I wanted to ask this audience is, can we forward reported incidents of drug diversion to you for your investigation? That's the call to action you'll hear me return to later on in the presentation. And there'll be plenty of time for Q&A. Feel free to type your questions in the chat window as I go, and then Carrie and I will answer those at the end of the presentation. So if you're not familiar with our organization, healthcarediversion.org, our mission is to reduce drug diversion in healthcare, not just hospitals, but all healthcare facilities. We really have 4 pillars in our mission. We're raising awareness and studying the size of the problem with a national database, hundreds and hundreds of drug diversion incidents that are in our database. I'll show that to you later. And it's getting a lot of interest from media and policymakers that it's happening often, diversion's happening in our own backyards, and we're glad to have that information available, and you'll see it in just a little bit. The second pillar is about connecting and collaborating with stakeholders, like folks at the state level in licensure boards or controlled substance authorities. We really see our role as to bring together collaborators from the public side and the private side and find ways that we can together reduce diversion in healthcare. The third thing we're doing is we're developing and promoting best practices to reduce drug diversion. We have a lot of people involved from the private side. These are CEOs of hospitals, executive at health systems, and they want to know, what can we do to reduce diversion in our organization? And we're also partnering on the public side at the federal and state level to find best practices for our policymakers, our regulators, and our law enforcement communities so that we can all play a part in reducing diversion in healthcare. There's many reasons that I and our board are so passionate about this. Why do we need to improve diversion prevention? The number one reason for me is improving patient safety, because all too often people who are diverting are impaired and they can injure their patients, particularly if they're tampering with medications, they can infect their patients. But I also see that we can work to protect coworkers. These are nurses and pharmacists and medical providers. If they are diverting, the sooner we detect that diversion, the sooner we can get them the help they need with their substance use disorder, hopefully before they hurt themselves or their patients. But there's also benefits to protecting our community. Increasingly, medications are being stolen out of these facilities and then sold on the street. And we want to prevent that and the addiction that comes along with that and the overdose deaths that comes along with that. So sadly, these are typically reported in the media where people are caught either stealing lots of addictive controlled substances that lead to all sorts of problems, or increasingly stealing non-controlled substances that are worth a lot of money, like the example on the right. One pharmacist at a VA medical center in New Jersey stole over $8 million of HIV medication and was selling it on the black market on the East Coast. So these are all examples of the sorts of things that are motivating us at our nonprofit to work together to reduce drug diversion in healthcare. Here's a little bit of the facts. We are a 501c3 founded in 2019. Our website's healthcarediversion.org. And we're all volunteers, myself included. We're volunteers looking to help achieve this mission. So who's involved so far? This is quite a busy slide, but this is our advisory board. There's representatives from just about every stakeholder that you can imagine. Starting the upper left, I'll just name a few. The Office of the Indiana Attorney General is collaborating. We've got national organizations like the National Association of Drug Diversion Investigators. One of the earliest founders was actually Matthew Christ from the Centers for Disease Control. His group is the one that has to get on a plane when there's an infectious disease outbreak caused by diversion. And so the CDC is really motivated to help prevent these. I won't read every line of a name here. You can see all these folks with a bio on our website. But we're really fortunate that we've got at the table stakeholders from the public side and the private side that are all looking for creative ways for us to collaborate and reduce diversion in healthcare. And we owe so much to our advisory board. Again, they're all volunteers, but they all bring their expertise and their perspective to helping us with this challenge. So moving right along, our approach, and I'll show you quickly our site. Our site has actually built a database of hundreds of drug diversion incidents. These are incidents that we can verify have occurred because organizations like yours have published, say, disciplinary records on your website, and we can confirm that this person was in fact diverting in this location in this method. We know we're never going to contain in our database every incident of diversion, but we're trying to get as many as possible, and we're collaborating with groups all around the country to load into our database as many incidents as possible. And the goal here is certainly not to shame anybody. Frankly, we feel that the more incidents we have in the database, the more we raise awareness. And we can see it's happening frequently. It's happening in our backyard. It's happening in our state and city. And we're hoping that in this way, we can raise awareness. We can also provide this data as a learning tool for education and prevention. And increasingly, this will be something I cover in a little bit. Increasingly, we're receiving reports of diversion from across the country. And these are incidents happening in my state, in your state. And we'd like to collaborate with state licensure boards, state controlled substance authorities, so that when we receive reports of diversion that have not already been investigated, we're already in communication with the proper people at that state level, so we can forward to you the reports that were received, but more on that later. So let me toggle over and give you a quick demo of the website. So here I am at healthcarediversion.org. This is our homepage. I won't go through everything here, but it basically allows us to let visitors like yourself or anybody that is searching on this topic to understand just how often diversion is happening, the kind of statistics that are available, the number of incidents in our database. And we do have incidents from all 50 states at this point. It lets people understand our values and ways that they can volunteer to help us. There's also ways that someone visiting our site can report an incident if they're aware of it. They just click this button to report the incident. Then there's instructions for how they fill out this form, but basically they tell us what they know about the incident. Sometimes these are incidents that are already reported in the media. Someone's been convicted or charged, and they can tell us about those kind of publicly known reports. And when we first started, those were most of the reports we received. But we also are increasingly receiving reports of diversion from people, say, that are working in a hospital. Maybe they've reported the diversion to upper management and they don't feel it's being investigated. They also have an opportunity to report it here. If someone fills out the report, we actually thank them for that. And then we encourage them to follow up with the appropriate licensure board or board of health or local law enforcement. We don't want them to report only to us. But we do want to be available to report the information, and then we want to be able to collaborate and encourage them to forward this not only to us, but to the appropriate authorities that can investigate the diversion in their areas. So I'll show you examples in our database that were reported using this form. You just go to the incidents menu. I also want to mention our advisory board. There's quite a bit in the About Us section, but as I mentioned earlier, we're so grateful for the advisory board, including CEOs of hospitals that really are passionate about the issue, folks that are trying to connect clinicians with substance use disorder treatment centers, folks that are looking to prevent fraud, waste, and abuse on the payer side. So just a lot of great folks that are collaborating with us to address the problem. So let me give you a quick demo of the database. If you want to see all incidents, you just come to Incidents, All Incidents. And this allows you to scroll down and see a map of all of the incidents that are currently in our database. I'll zoom in just a little bit. When we first started, we just had a few dozen pins. Now we're up to over 600. Basically, each pin is one healthcare facility where diversion has been reported in our database. They're color coded. The red ones are hospitals. The orange ones are all other types of healthcare facilities. And you see some of these are actually coded with a star. That means a patient was killed as a result of that diversion. Or a square, that means patients were infected as a result of that diversion, or a diamond means patients filed lawsuits as a result of that diversion. If you ever see a pin with multiple, or with a little circle underneath it, I'm in here in Georgia, so I'm going to zoom in. This particular location had more than one facility, more than one diversion at it. So the whole goal here is I can zoom in on any area of the country. When we show this to the media, for example, they're always zooming in on their own location, their own neighborhood. I'm going to just zoom in here on Metro Atlanta where I'm at. So you can click on each one of these pins and see a summary of the incident. This happens to be a well-known incident at Emory University Midtown Hospital, where 2 pharmacy technicians stole more than 2 million doses of drugs. And on any of these, if you want to see more details, you can click and it'll bring up all the details of this particular incident. One thing that we are finding is the search engines like Google are using this information so that if people are searching searching for examples of opioid theft, searching of examples in Georgia, searching for examples of diversion that have financial losses. Increasingly, the search engines are pointing those people to individual pages on our website, which we think is fantastic. Because again, the whole goal is to raise awareness of how often this is happening and that it's happening in our own backyards. And all of these, we've already verified against publicly available news reports. So people can click to drill down and see the newspaper articles discussing this particular incident. Or if there was, say, a press release from the Justice Department or the DEA or somebody like that, you can drill down into those details. So that's an example of how fast it is to see what's in the database in your own backyard. If I zoom back out again, we've also built some capabilities to really study the size and the scope of the problem. So for example, we were contacted recently, people were interested in the theft of morphine, and it's easy enough to type in any drug name here. I'll just do morphine. And now it'll filter the database to just occasions of diversion associated with that code, that type of drug, morphine. I should have said this earlier, beneath the map, it shows a list of summaries and addresses and facilities and when the information was added to our database. And of course, I could click here, just like I click on the link, and it'll bring me to the details of that particular incident, which happens to be one in Missouri, a paramedic that was stealing both fentanyl and morphine. So that's how easy it is to search by a drug name. You can also do it by profession. So you can drill in and see just incidents by nurses, just incidents by people in pharmacy, including pharmacy technicians, anesthesiology incidents, physician incidents, and all others. That's pretty easy to do. Another thing that we're raising awareness of is how sometimes people are serial diverters. There's a famous case you're probably familiar with by David Kwiatkowski. And if I just want to see cases with his name on it, or anybody's name for that matter, I can just type their name in. And if I spelled it right, it's going to show us all the hospitals at which David Kwiatkowski worked. And he was a serial diverter, started out west, and anytime he was where he felt he was going to be detected, he just resigned from that facility, and as a traveler went to lots of other facilities. I lost count. I think there's 16 different facilities where this one surgical technician worked. He diverted in all these locations. Along the way, he picked up hepatitis C, and he was taking the syringes before surgery and injecting them into his own arm. He was replacing that with water. Then that got injected into a patient, and then the patient wound up with hepatitis C as well. And several patients did die along the way or contracted hepatitis C. So this is an example how we can show people that might not realize, hey, it's often not just one isolated case, but someone who's diverting across multiple facilities, injuring and even killing patients. Another thing we've gotten a lot of interest in is you can click this advanced search and you can start to search even more specifically around just about any details you can think of. If you wanted, for example, to just see incidents in a certain state, you can do that. One that we've got a lot of interest from the Food and Drug Administration's Office of Criminal Investigation is tampering. That's their jurisdiction, and we're partnering with them. I'll tell you a little bit more about that in a second. And so now these are cases where someone's diverting by substituting the drug. You know, they're dispensing, say, morphine or fentanyl. They're removing the medication out of the vial or syringe. They're replacing it with water. And in that way, they're diverting. So lots of tampering cases here. And you can see from the symbols, a lot of those lead to patient infections or injury or death. Another one is we have people in the media contacting us, show me just the ones where patients were injured or infected as a result of the diversion. And just as easily, we can filter the database down to just those. And sadly, there's way too many occasions where people are either exposed to hepatitis C or the provider is practicing while impaired and killing their patients as a result of their diversion. So again, the whole goal with this ability to sort is to raise awareness of how often diversion is happening, how dangerous it is, how many people are being hurt, and that it's happening in our backyard. And there's plenty more ways that you can search One thing we're very excited about is we just released a new capability so that if you don't want to just come to the website and search for new incidents, maybe in the old days, we had to come in once a month and search and had to remember, did I see this one or not? We've added this feed here, this little orange button. And when you click the orange button, it actually gives you a computer readable list of whatever you've typed into the search bar. And you can subscribe to this as an RSS feed if you're familiar with the technology. So let's say you're in Georgia, as I am, and you want to know anytime a new incident has been added to our database, you would just come in and search on what you're looking for in Georgia. I might occasionally see something that's like the person's name was Georgia, but most of these are going to be in Georgia. And if I drill down, of course, I could see these in the map and click on all these individually. But if I want to save myself time, I just click on this little orange button and it's going to give me a website up here. I can copy this website URL. I can paste that into my email system like Outlook or Gmail or whatever your RSS feeder is. And now anytime a new dot is added to the map in Georgia, I'll actually be notified via email. And that way I'll know it's been added within a few seconds of it being added to the database. So we're excited to be able to offer that to folks that want to stay in tune to particular types of diversion. So hopefully that's a clear demo. There's a lot more on the website that's available. We're really proud of this growing list of resources. We call them best practices for reducing drug diversion. We got a lot more work to do. It's going to be a many-year journey. As we work with hospitals themselves, when we work with public regulators like licensure boards or controlled substance authorities, we want to publish best practices that the hospitals can do. We want to publish model state drug laws that can allow us to reduce diversion from the public side. So we're growing our resource center for best practices. But I will say what we've gotten the most feedback for so far has been our database that allows people to see the diversion that's happening either across the country or in their backyard. So hopefully that demo was clear. Feel free to take a look at that at leisure. And at the end of the presentation, I'll give you my email. Happy to answer any questions you have on how the website works today. Also happy to get any suggestions you have. We're continuing to innovate on the website, and I'd really welcome any suggestions you have to improve the database, improve the website. Any suggestions are welcome. So now on to my big ask for today. The reason I had reached out to NASCSA to present today is to really ask, can we forward reported incidents to you? And let me give you a little background and then ask you the question again. Bottom line, we want to collaborate with state-controlled substance authorities so that we investigate and reduce drug diversion in healthcare. Again, we want to collaborate with you. We want to bring you at the state level on the public side together with all the other stakeholders that we've got at the table. And increasingly, we want to collaborate with you so that when we're told diversion's happening in your state, we want to be in a position to forward that to you in the right way, to the right group, so that it can be investigated appropriately. So just to peel the onion a little bit, I showed you on our website how you can report an incident by filling out that form. Most of the incidents that we've received, of the hundreds that we've received, have already been investigated. So for example, a good example is a state licensure board, let's say here in Georgia, has investigated a medical provider for potential diversion, and their investigation has led to adjudication and a disciplinary record. So on the state of Georgia Board of Nursing, for example, website, we will have found that incident and that will have been verified in that way. So the majority of our incidents come in that way. However, we are seeing more and more incidents being reported to us that we can't find any information on. There's no sign that it's been investigated. There's been no sign it's been reported. There's certainly no been sign it's been adjudicated. And so these are the ones I want to focus attention on for the next few minutes in the presentation. These are incidents where someone has taken the time to fill out the form and we receive it. We will not put that in our database. We don't know if it's a legitimate accusation of diversion. We don't have the resources to investigate. It's not our responsibility or role to investigate it. If we can't find any third-party verification on that, we move it off to the side in a part of the database that's not on our website. And that was fine for the first year or two of our organization. But when we started to read these reports, frankly, we felt compelled, our board of advisors felt compelled to reach out to the appropriate authorities at the state level or the national level and find a way that we could forward these incidents to the appropriate and responsible investigators. The organization we partnered with first, we're really proud about. That's the Food and Drug Administration's Office of Criminal Investigations, often abbreviated FDA OCI. If you're not familiar with this group within the FDA, they were actually formed by an act of Congress right after the Tylenol cyanide poisoning decades ago. That's when Congress said we need a federal investigative law enforcement group so that if someone's tampering with medications, we've got resources at the federal level that can investigate that tampering. Well, fast forward to today, this is still their jurisdiction. If there's a crime involving tampering of medications like the ones I mentioned earlier, then FDA OCI is responsible at the federal level to partner with the local law enforcement, state regulators, state authorities to investigate that criminally. Long story short, the FDA OCI approached our nonprofit about 3 years ago, saying, we notice in your database you have tampering cases, but you're only publishing the ones that have been verified. Could we do a pilot so that if a tampering case was reported to your website, you could forward that to us at FDA OCI, and then we could investigate it? We thought long and hard about that and decided yes. And then in the interest of patient safety, again, there's a lot of patients being infected or killed as a result of diversion. We really felt we had an obligation, an ethical obligation, if we received a report of tampering, that we would forward that to the FDA OCI, and they would be in a position to know if this was a legitimate accusation. They would be discreet and professional and confidential and well-trained to be able to do the investigation on whether or not this in fact was diversion as a result of tampering. I'm not today going to share specifics of individual reports, but I will tell you that FDA was so excited by our initial pilot, they have since expanded nationwide. So our initial pilot was for the 7 states surrounding Chicago. When we forwarded incidents to them, they responded not with the details of their investigation. We don't want that, but they did respond saying this was definitely worth us investigating. They said it was a good use, a good mechanism for them to be aware of cases they would have otherwise not been aware of. And they asked us to expand to all of the states surrounding the Kansas City FDA OCI office. And then recently, about 6 months ago, they asked to expand nationwide. So we won't share any confidential information about the kind of cases we forwarded and the kind of investigations or the results of those investigations. But we were really proud to share this quote that they authorized us to share, that the FDA's Office of Criminal Investigation supports the work of healthcarediversion.org and encourages our members to send information about potential tampering to not only them, but also other law enforcement entities. So it was this pilot where we were forwarding tampering cases that got us as an organization thinking about how could we collaborate at the state level so that we could be forwarding diversion incidents to state investigators, state licensure boards, boards of nursing, boards of pharmacy, medical boards, as well as other controlled substance authorities or law enforcement organizations at the state level. And that's really led to today's presentation. So here's my urgent plea. This is some really compelling data. We are receiving an increasing number of reported diversion incidents. We can't find any public record that they've been investigated. We've got 143 of them so far, and we get more every week. These are reports that we're receiving. We don't put them on the website because we can't verify them. We can't find a disciplinary record. We can't find a press release on the criminal indictment, anything like that. But we don't have someone to forward them to. We're forwarding to the FDA OCI, as I mentioned, but that's only 2% of the number that we've received. And we are reaching out right now to you in the audience to ask if we're in a position to forward these incidents to you, if they're in your state, so that they can get to the right person who's trained and can handle the investigation to see whether or not that's diversion. And hopefully in the process, if it is diversion, prevent that person who's diverting from hurting their patients or themselves and all the other victims that are harmed by diversion. So here's an example. I'm just going to slow down. This is a real example. It's in our database, but it's not published on our website. This is someone who's filled out the form. I've worked at this facility. I'm concerned about this nurse. Each time the nurse counts off, the count of syringes is off and her behavior is odd. There's been several staff members noting this nurse has been sleeping on the job, administering insulin at the wrong times, stealing narcotics. Apparently this clinician's been terminated in the past for stealing narcotics. They've been reported to the supervisors where she's currently employed. She refused a urine test upon last time of being employed at this facility. Again, just continuing the report, I fear she is in danger to the residents, especially administering insulin, using the wrong syringes. I feel my supervisors are not doing appropriate discipline. I and many other registered nurses have sent emails regarding our concerns. I hope you find this matter a high priority, as it seems the supervisors are not concerned about this RN. So again, our advisory board really feels an ethical need for us to get this information into the right hands at this nurse's state licensure board, or whoever that state tells us we should forward this to, so that it's not just a report that's sitting idly in our database, but it's actually the kind of information that can be investigated. And given the kind of attention and resources that will hopefully protect patients from being injured. And if this person does in fact have substance use disorder, can hopefully get them the help they need with their disease. So I'm nearly to the end of my presentation. We're going to open it up for questions. So we are really flexible on how you would like to collaborate with us. My ask is a simple one. If you would like to talk about how we can forward incidents in your state to you, please send me an email or give me a call. That's my personal cell phone number. I would like to hear from you. I would like to know, hey, I'll just take Georgia, my home state. I am on the board of nursing for Georgia. And if you have an incident in Georgia involving a nurse, please forward it to this email address. That's all we really need to be able to forward that state's diversion incidents, at least for nurses. So if you are interested in talking how this could work, if this could work, that's my call to action for you. Please shoot me an email or give me a call because we would like to find a way to collaborate with you at the state level so that these aren't just sitting in our database without anyone knowing whether or not they're accurate accusations or not. So hopefully that's clear what I'm asking for. And now I think we got plenty of time, Carrie, for questions and hope there's lots of questions from the audience.
So this is Kathy. I do have a question that's in the box, which I will read, and I encourage anybody to chime in with any additional questions. One thing that I will definitely share with you, I was texting somebody from our board. We'll put a link to healthcarediversion.org as a resource on our website under helpful links, I think it is. And we will also be sharing a copy of this recording on our YouTube channel, probably in 6 to 8 weeks. So just wanted to let people know because we certainly have a number of people listening in, but there's a number of people who have not registered for this program. So the one question that I had, is it okay to share information with our home state? I'm with a board of pharmacy. Is it okay to share information with our home state?
So the question is it okay for us to share with them at the Board of Pharmacy, Kathy?
I think that's what the question is.
It's certainly okay from our side. That's exactly what we're hoping will happen. Here's what we want to do. We want to know that you are receptive to us forwarding the incident to you at the Board of Pharmacy in your state. And all we really need to know is to whom do we forward it? We want to be sure it's getting into the right hands so that it can be investigated appropriately.
Okay. Any other questions? You don't see anything right now.
Tom, I have a question. So just take me back 1 second through your slides, if you wouldn't mind, while we're waiting for further questions to come in. I was, so if I am a facility and I have a worker, Kathy Keogh there, that I suspect is diverting, and can I go to your website and search based upon the name of the individual?
You can.
Yeah, so that's really handy because I know sometimes investigators get it down to 1 or 2 people that they think maybe, have the potential. And I've been involved in an incident where the director of nursing said, "Hey, Google this name for me," and it pops up that he was convicted not all that long before he started working there, but it just hadn't made the news yet, or he was indicted perhaps, and then the conviction actually didn't occur until later. So very interesting that potentially those could be looked at ahead of time. Looks like we have some more questions, Kathy.
Yes, they're starting to pop up. Hi, Tom. Do you have any plans to expand to cover diversion by pharmacies in the organizational side, i.e. points of transfer during transportation has always been an issue?
Yes, in fact, we have some already in the database, diversion incidents by either people working in pharmacy or people shipping products to pharmacy. So yes, we're very receptive to putting those in the database and have a few already.
Okay, the next question, are you reporting these to DEA?
Not yet. We'd be receptive to doing that, but so far at the federal level, we're only forwarding tampering to the FDA OCI.
Okay. When you get these allegations of diversion that aren't public knowledge, do they mention more details like the name of the person or name of the facility?
Mostly, yes. We are finding that people reporting give us the name of the facility, they give us the name of the clinician that is diverting, at least that is suspected of diversion. It's often quite detailed, and it will give us, on this date and time, this patient's medication was stolen and the patient did not receive their medication. So there's often very good detail in the report. And we would, of course, forward all that detail to the investigators so they could follow up with the right people. We've also added a field. This is a recommendation by the FDA that we added a field to the report. It's called manager or responsible individual for the facility. And in that way, we get not only the name of the person that's suspected of diversion, but we get their supervisor or we get the site director of the facility. And so that has been helpful to the FDA. They make their first call into the facility at the management level so that they can conduct their investigation confidentially with the management informed. So yeah, a short answer, very, very detailed. Typically, there are occasions where the person reporting don't know the name of the person diverting. The most common example is we'll get a patient calling. We do, by the way, have a 24-hour hotline where you can call and report. And we'll get a phone call that, I went to pick up my medications at my pharmacy, my neighborhood pharmacy, and there were supposed to be 30 in the bottle and there's only 22 in the bottle. And in those cases, they know the name of the pharmacy, but not necessarily who it was in the pharmacy working that might have shorted the dispense. But they're typically detailed enough that we get medication names, facility names, dates and times, and sometimes even more detailed than that.
Okay, so I have several other questions. What sources do you use to validate the charges? Provider data bank, news stories, other sources?
Yeah, we use Google a lot where we'll type in the name of the person reported, maybe the facility name. And more often than not, we find third-party confirmation at a state licensure board website in disciplinary records, where we can see that that person was adjudicated and the board found diversion happened. We can find that in disciplinary records. That's the place we prefer to do it. That way we know that responsible public investigators, regulators have conducted the investigation and the adjudication and confirmed diversion happened. Occasionally, we'll get press releases from the feds. We get a lot from the U.S. Department of Justice. They'll publish indictments, convictions, and sentencing. So that's another source that we commonly use. Occasionally, Google will see a local media report, like a local news channel did a profile of someone who had been convicted. And then in most cases, we're able to dig deeper into the source documents like the criminal record. Occasionally, we'll have the ability to search public databases like NASCSA for nurses, has disciplinary records and things like that. But long story short, if we can't find one of those reputable third parties, we don't publish anything on the database. In fact, we had from our beginning a rule that if someone has been indicted but not convicted criminally, or they've been accused but not found through administrative action to have diverted, we will actually de-identify the report. So it will say an unnamed nurse was indicted. And then if a year later we get record that they were convicted and sentenced, then we will go in and re-identify it. It'll be Nurse Tom Knight was convicted. So we really take steps to only publish we can verify. And if someone hasn't been found guilty criminally or administratively, we will de-identify it so their name's not associated with the report.
Okay, and just a couple more questions. Why aren't reporting individuals reporting to the state boards?
It's a fair question. We actually show right on our website, don't tell us only, tell the state board or other organizations to whom you should report. I can't say why it's not being reported to the state board. Frankly, that would be the best place to report it. I will say that sometimes people don't know there's a board of nursing that this should be reported to. And it can sometimes be complicated to know who do I report to. Most people don't know that tampering cases are supposed to be reported to the FDA, OCI, for example, or they might not know that if infection risk is a possibility, it should be reported to the Board of Health, in addition to law enforcement or licensure board. So one thing we do show, if you ever send a report in, you can test this if you want. If you report to us, the next screen you see is, hey, thank you for reporting to us, but you really need to report if it's involving a licensed individual. Here's the Board of Nursing or Board of Pharmacy or Medical Board. That's who needs to get this information. And right now on our website, we even say we will not forward this. And frankly, we want to be able to change that and say, we want you to report it directly, but we also want to be able to say that we can forward it to at least most of the states, if not all the states someday.
So you could certainly also, if you wanted to, under our state profiles on our website, you could also link, because even if it isn't the exact person that's, that would investigate it, they would know who to refer it to or give that person a phone number or an email address if need be.
Mhm.
The other question I think you already answered, but I'm going to scroll down. But one question I had is, have you done anything as far as communicating with national, like the Federation of State Medical Boards, to let them know that you exist and the reports that you're getting that may be of interest to them?
We've had some success there. I think there's a lot more work to be done. We've reached out to the National Association of Boards of Pharmacy, NABP, and they were very generous and actually invited me to their annual conference so that I could network with their members and talk about this issue. We've had less success with the National Association of State, or sorry, the National Control, oh goodness, the equivalent for the state boards of nursing. Forgive me for forgetting the acronym for the National Council on State Boards of Nursing, I think is the right one. Sorry, took me a moment. We haven't had as much success, but we'd love to collaborate with them. And then also the medical board organization you just mentioned. I think there's a lot we could be doing at the national level. Frankly, if any of you in the audience would like to make an introduction between the National Association that represents your licensure board and our nonprofit, I would really welcome that. The only one so far that we've had a lot of good substantive discussion with has been the National Association of Boards of Pharmacy.
Okay, the other thing is not necessarily a question, but rather an editorial comment. The state boards are overwhelmed and do not respond in a timely manner. One state is about 5 years deep in responding to physicians and OD disciplinary action, and California is even worse.
Yeah, I won't dispute that. I do know there's leading states out there that are adequately resourced and are on top of the investigations. Part of what we as a nonprofit are hoping to do by raising awareness is to get policymakers to adequately resource licensure boards at every level and every profession. That the lack of investigation resources leads to those many year backlogs, and that's not good for our patients or our public health. So if you're in that situation in your state, I certainly sympathize, but we'd still like to find a way to get that information to you so that you can do the best you can, even if you're not fully resourced to investigate it.
Okay, I have, I think, one more question. Does the, Mary Lou, by the way, you're on fire. Clearly you're paying attention. Does the FDA share 3911s and DEA share 106s, 107s?
No, we're not getting information from either of those organizations.
Okay. All right. I don't see any other questions, Carrie. I can.
Okay. All right. Well, I just wanted to make a comment. I know from a boards of pharmacy standpoint, I think many of us would take your information and allow you to send those to us. But from our standpoint, we don't have a lot of jurisdiction in healthcare facilities unless there's a licensed pharmacy there, or long-term care facilities is really, I know, probably one of the largest diversion locations that we have. And since those medications are actually already a patient's, that gets into more of our DCI or someone like that. So I can understand your concern about not having the right person to report to, because there are probably many people that you could be reporting to. And so, I think a lot of us at boards of pharmacy or controlled substance scheduling authorities would be willing to be on point for that. But as far as a follow-up or anything, I'm not sure, if we are the ones to do that. So just FYI.
That's great feedback. And if you would be so kind to email me with any suggestions you have, if only to say, don't send them to me, to send them to this other person. I'm really hoping to learn from NASCSA members how we can interface with the right people in each of the states.
Fantastic.
I would just say we'll certainly do our part to sort of put a link so people know about it, and put the YouTube video out, which you could direct people to also. I think it's a helpful tool and resource for people.
So thank you, Kathy. And thank you for the opportunity to present today. I really appreciate it.
Yeah, Tom, this has been fantastic, and doesn't appear to be that there are further questions in the chat. So thanks for sharing your insight and expertise. It's been amazing for us to learn about this organization and how valuable you are. So, thank you again. Thanks, Kathy. I think this has been excellent education for our NASCSA membership. On behalf of the National Association of State-Controlled Substance Authorities, we would like to thank everyone for joining us today on this webinar, and thank you to the sponsors once again, and we wish you a wonderful rest of your day.
Oh, I just wanted to say one thing. We got one last comment in the chat box. So Tom, you got a live one from, I'm with the Drug Enforcement and Professional Practices branch in Kentucky, and I will be contacting you as our division is over all controlled substances in Kentucky. So
Thank you so much. And thank you again for anybody that can help us out, and contact me via email or phone, whatever is most convenient for you.
okay, thank you.
Bye-bye.
Super. Thanks a lot. Have a great rest of your day.